Why do surgeons sometimes make incorrect decisions by ignoring that a patient's presentation is unusual and requiring a different approach? During surgery, why do they occasionally cut something they shouldn't? They do so not out of carelessness, but because they are influenced by a bias called representativeness. In other words, they forget that similar does not mean identical. Hello and welcome to this channel dedicated to achieving surgical excellence. Today we will examine the thinking error known as representativeness. It occurs when a surgeon assumes that patients' problems are the same as typical cases, even when they are not. This can lead to misdiagnosis or, if it happens during surgery, to surgical complications. Whether considering the patient's clinical problem or surgical anatomy, you might think it is similar to a typical case, but we must remember that there is a difference between the same and similar. Although we often use these terms randomly, the same means complete identity, whereas similar indicates near identity but not quite the same. Still sounds confusing? I will explain this first with a general example and then a clinical example. Imagine you are at a party. There you are looking for a friend with whom you were supposed to meet. While searching among the crowd, you spot her from behind. You call her, but she doesn't respond. You think she hasn't heard. So you walk closer and shout her name again. Still, she doesn't respond. You become a bit annoyed. Move very close to her, tapping on her shoulder. You ask her, "Why are you not responding to me?" She turns around and you realize that she is not the friend you thought. It was someone else who looked like her from behind. So you mistakenly thought she was the one you were looking for. That's the representative bias in action. In such a day-to-day situation, you have a chance to get corrected immediately. But that may not happen in a clinical situation. In a clinical scenario, if a patient presents with symptoms that resemble a typical case, a prototype, you assume they have the same condition without considering other possibilities. Here is a true story. A 40-year-old male patient who was working as a fitness instructor in a gym came to the emergency department of a hospital late in the evening with complaints of chest pain for a few hours earlier. The emergency department registrar examined him. The assessment didn't show any symptoms other than retrosternal chest pain. The registrar reviewed the checklist of risk factors for cardiac problems but didn't find any. As a fitness instructor, the patient led a very healthy lifestyle and was in excellent physical condition. The clinical examination, cardiogram, and other investigations, including cardiac enzymes, all returned normal results. The patient was reassured that the pain was likely to be of muscular in origin and was advised it was safe to go home. 8 hours after being discharged from the emergency department, he was readmitted to hospital with a massive myocardial infarction and unfortunately died the following day. So, the question is whether the registrar missed the diagnosis due to lack of knowledge or negligence. In fact, it was neither. When this case was discussed later, it became clear that the registrar was influenced by representativeness. He was especially influenced by the healthy lifestyle and physical fitness of the patient. His judgment was affected by the fact that patient had healthy lifestyle and very fit body. Had he been aware of his biased thinking, he might have realized that the patient could have unstable angina and that laboratory investigation during the window period might appear normal. Because the patient's presentation didn't match the risky category, the registrar concluded that further monitoring wasn't necessary. In case of representative bias like this, thinking is guided by prototypes. So options contradicting the prototype are ignored. We all have heard the phrase, If it looks like a duck, walks like a duck, and quacks like a duck, it is a duck. Our pattern recognition is based on this principle. We are often told common things are common. In pattern recognition, you match the patient's clinical features to the mental template or prototype. Once you are satisfied with that match, you make the diagnosis. This works most of the time, but not always. Blindly relying on this strategy risks missing atypical presentation. Here I want to give an example from non-clinical area, from the investment domain. We see warnings at the bottom of the investment brochures. Past performance of the fund cannot guarantee future performance. They do so to prevent investors from making errors due to representative bias. Here is a short clip about this bias and investment decisions.
What's the one thing that kindergartners and professional investors have in common? It's that they love a good story. When people process information, they draw analogies to what they think is a similar situation. Oh, that reminds me of blah, blah, blah. This is called representative bias, also called similarity bias. This bias can be especially problematic in investing because when you're using the similarity bias to process information, you're processing information on something that happened in the past. You know the outcome already, rather than what's happening right now. Be really suspicious of articles saying something is happening that hasn't happened since 2008. The authors of those articles are using the representative bias to get a reaction out of their readers. So make sure that when you're investing, you're focusing on this particular situation, what's happening right now, and not what has happened in a story that you're reminded of.
So, the question is, what can you do to avoid this bias? The first step is to become aware of this bias, which you have done by now by watching this video thus far. The next step is to recognize that anyone can be affected by it. Then the following step is to challenge your own assumption about patients based on stereotypes, especially if those assumptions are based on limited information. You may face such situations in emergency cases, in emergency surgery where waiting for full information is not possible. In such cases, you need to scrutinize the available information more carefully. Seeking another opinion is a common practice to avoid this bias. These are the steps you can take before making the decision. After the decision is made, once you know the outcome, you should spend some time in self-reflection and discuss the case with others if there were any issues. In conclusion, we all can fall prey to representative bias. Rather than blaming carelessness or ignorance for the errors, it is important to take steps to reduce the effect of bias by developing awareness, relying on objective data, collaborating with colleagues, and engaging in reflective practice. We can improve our decision making. Thanks for watching this video. If you found it helpful, don't forget to give us a thumbs up. Subscribe and hit the notification bell for more insightful contents. Thanks.